Okay, today we will be discussing. See, I have already uploaded the adverse events following immunization. This is a topic which is, has been, the PowerPoint was prepared by Dr. Amal about 2 years ago and is prepared entirely on the basis of 2022 immunization book by the Indian Academy of Pediatrics, which I found to be the best. And it has been asked many times. They ask you mainly 5 mark questions on that. The whole topic is asked as 5 marks. Sometimes only a portion of it, like when do you report, what is the causality assessment, a portion of it is asked. Therefore, we will go through it fast. I hope you have seen the PowerPoint presentation. And therefore, you can now answer. Now onwards, we won't be putting up the PowerPoint presentation. Is up to you to read it. I'll only put the MCQs, but we will go back onto those slides as we go ahead. Now, Majida, can you read it now?
Which of the following best defines an adverse event following immunization?
Okay.
The answer will be any untoward medical occurrence that follows immunization and may or may not be causally related to the vaccine.
Okay, that's great. That must be the answer. All right, let's go to it. You're right. Is there any untoward occurrence following, regardless of whether it's cause related to the vaccine? It looks a very simple sentence, but I want to tell you very important points in this. See, any untoward medical occurrence which follows immunization, which does not necessarily cause causal relationship with the usage of the vaccine. Examine, might not. Can you read it? Can you read the whole thing?
And an adverse event following immunization is an untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the usage of the vaccine. That is, might have not been caused by vaccine ingredients or the process of vaccination or immunization, but have a temporal relationship with the administration of the vaccine. It can be any unfavorable or unintended sign, abnormal laboratory finding, a symptom or disease. Sometimes mass use of vaccine can cause anxiety in community, and even such responses can be considered as an AEFI.
Okay, this is very, very important. For the definition is very important. It's not as simple as you think. It need not be cause. It can only be temporarily associated with the administration of the vaccine. Remember this. I gave a vaccine. 20 people developed vomiting, got admitted in the hospital. The moment you report it as AEFI, I'm sure some pediatricians, even non-pediatricians, will be on your throat. Why are you making trouble? Why are you causing a problem? Remember, you must stand on your feet and say, a laboratory finding, see what is given here, or disease. Sometimes mass use can cause anxiety in the community. Therefore, if anxiety in the community, patients, other children will start fainting, and but they will be brought to the hospital. If you don't report, you become the person who's responsible is the person who administered the PDA immunization. Therefore, if you don't report it, it is your responsibility. The DMO might have told you don't bother. The medical officer in charge would have told you don't bother, because he doesn't know that the even anxiety in the community of parents, you should report it. Later on, it doesn't mean that is a cause. He will say, doctor, how can this be the cause? What are you talking? How can a child given DPT become 3 days later unconscious? Or 10 people in the ward, hospital also developing MMR vaccine given, 20 people developing vomiting and diarrhea. Why are you concerned? No, it's only the temporal relationship with the administration of the vaccine. Anyway, we go again. Okay. Read it.
Which of the following is an example of a vaccine product related reaction? A. Paralytic polio after IPV due to incomplete inactivation. B. Sterile abscess due to frozen DPT vaccine. C. Extensive limb swelling after DTP vaccination. D. Vasovagal syncope in an adolescent after vaccination. The answer will be C, extensive limb swelling after DTP vaccination.
Very good. Inherent properties cause product-related reaction, extensive swelling of the limb expected. Now, this is a very important point. We will be going into individual vaccine and the reaction. If you get a DPT injection, sometimes what happens is there is a swelling and redness around the point. Now, if it crosses a joint, okay, crosses the joint, then you will have to report it. Suppose you give it in the thigh and crosses the knee joint, then you will have to report it. Otherwise, no. But always remember that they say that the what you call the diseases and the reaction, don't read the textbook. If it is causing anxiety, everything, report it and show it to the surgeon also. I have seen one patient where the pediatrician kept on telling that the general practitioner actually in Oman kept on telling even after 2 or 3 visits, this is nothing but reaction DPT. It is given in a book. She counseled them. But after 4 or 5 days, it so happened it was an osteomyelitis and the patient almost lost his femur. Therefore, this is an extensive limb swelling is well known after DPT. That you can read this, etc.
Cause-specific types of adverse event following immunization, vaccine product-related reaction, and AEFI, that is caused or precipitated by a vaccine due to one or more of the inherent properties of the vaccine product or ingredients. Example, extensive limb swelling following diphtheria, tetanus, and pertussis vaccination. In this scenario, vaccine might have been used correctly without compromising with manufacturing process, transport, or storage. Thus, absolutely correct use of vaccine may also cause this type of AEFI. In most cases, such events are usually not serious in nature.
Now, this is where your knowledge comes into fact. You have into action. What happens when the moment the patient develops a redness and swelling and everything, if you refer it to the surgeon, he will immediately write cellulitis. Okay? Don't refer. If you refer, you go and tell him this. The moment you turn to cellulitis, the accusation will come on the hospital and the hospital will put it on the nurse who gave the injection. But you must say that this is a normal vaccine protected reaction. And this absolutely correct use of the vaccine may also cause. You will have to explain to the parents this. They may not be happy. They may go and give a complaint. You may also treat it as cellulitis, as a different thing. But at the end of the day, you must know this point very clearly. This vaccine protected reaction. This has nothing to do with the way it's not a cellulitis. And therefore, it cannot be the mistake of anybody. Okay, okay.
A 6-month-old infant develops paralytic polio 10 days after receiving IPV. Investigation reveals the vaccine lot was incompletely inactivated. This is classified as A. Vaccine product related reaction, B. Vaccine quality defect related reaction, C. Immunization error related reaction, D. Coincidental event. Answer will be vaccine quality defect related reaction.
It is not quality defect. It is a mistake on the part of the person who administered it. Reveals the vaccine was not, lot was incompletely inactive. Yeah, it must be right. You are right. You're right. This is a vaccine quality defective reaction because the adverse event was caused by manufacturing defect, incomplete. You know one thing that you see now, since there is some time and to only Maji, you must know the history also a little. Actually, initially when the vaccine came, oral polio and IPV was very, very together. They were competing for the market, and even at that time the virologists were not happy with oral polio. They were telling, look, oral polio can become the what is now happening. You might have inactivated it, but over multiplication it might become virulent. That is overruled because what happened? Some of the inactivated vaccines, which were given by Salk, unfortunately became were not completely inactivated, and that caused an epidemic of polio. And that's how Salk vaccine went into severe disrepute. So this is an incomplete inactivation of the virus. Yes, it is a vaccine quality related product. Now,
Um, For reuse of a disposable syringe during a vaccination session leads to hepatitis B transmission. This is categorized as A. Vaccine product related reaction, B. Vaccine quality defect related reaction, C. Immunization error related reaction, and immunization anxiety related reaction. Answer would be C. Immunization error related reaction.
Okay, carry on. That's right. Can you read the answer?
Answer is C. Immunization error related reaction result from inappropriate handling, prescribing, or administration, such as syringe reuse, which is preventable.
Okay, read it.
Mm. A child receives BCG vaccine subcutaneously instead of intradermally and develops a large local ulcer. This is an example of um, vaccine product related reaction, then vaccine immunization error related reaction, coincidental event, and D is immunization anxiety related reaction.
What's it?
Uh,
It's so
Again, immunization error related reaction.
yeah. BCG must be given intradermally. Now, let me tell you one thing here, that the question is not very well. It should have been a huge lymphadenitis. Suppose a patient is given BCG, okay, and
Mm.
1 week later he comes to the ER with a swelling on the axillary lymph node. What will you tell the patient?
Mm.
Ashwati, what will you tell the patient? Ashwati has disappeared or what?
Hello.
What will you tell the patient? Some immunization has been given. The patient develops a swelling of the axillary lymph node. It is becoming bigger. 1 or 2 weeks later, she comes to the emergency. You are going and seeing the patient. What will you do? Majida, what will you do? Ashwati is remaining silent. If you don't know, you say don't know. Don't
Um,
waste the time. Okay.
mm,
Majida, what's the answer to it?
uh, mm,
The mother says, look, one of my dog, I have a distant cousin who is a doctor. He said it's a mistake of the hospital and they have given it in subcutaneously, and that's why it caused the BCG lymph node. What will be your answer to it? See, one of the commonest problem now, often severe BCG lymphadenitis, when you give subcutaneously, it does happen. But even when you give intradermally, it happens. Remember that. What you should say
okay.
is, it is a good sign that it is taken up. That means the BCG has been taken up by the child and the child is reacting to it. Unless it becomes very big, spreads beyond the axilla and lymph, or it forms an ulcer, you normally will never treat. That's a different chapter altogether. Here he has written, given he subcutaneously develops a large ulcer. I don't think you will develop a large ulcer. When you give it subcutaneously, normally you develop severe BCG lymphadenitis. That's the usual thing. But when you see a BCG lymphadenitis, never blame the doctor, never blame the nurse, because it occurs normally also. In fact, it might even be a good sign because the patient has become immune. Okay.
Yes. Yes. A 5-year-old girl faints immediately after vaccination in the clinic. She recovers within 2 minutes with no residual effect. This is vasovagal syncope. Answer.
You're very fast in answering. Okay. Read it. Read the answer.
Vasovagal syncope is a type of immunization anxiety related reaction. It is common in older children and adolescents, especially in anxiety provoking situations like injections.
Okay, next one.
A 9-month-old infant develops fever and malaise 6 hours after DPT vaccination. A blood smear shows Plasmodium falciparum. This event is classified as option A is vaccine product related reaction, B is immunization error related, C is coincidental event, and D is immunization anxiety related reaction.
Okay,
Answer will be C, coincidental event.
okay. Read the answer also.
The fever is coincidental and due to malaria. not the vaccine. Despite temporal association, the cause is unrelated, hence a coincidental event.
Therefore, that's why all incidences you should investigate in a proper way. It might be coincidental also. Now, Faris has also come, I think. Am I right, Faris? You are there?
Yes, sir.
You are on duty.
Yes, sir.
Where are you?
I'm in fifth block, room side.
Room side. Okay. Now, let me ask you a simple question. Patient is given okay today morning. See, child is given immunization in the. Suppose you say now it is. I know it is 7 o'clock. Immunizations are not given. I don't know if the clinic is closed. Suppose they give immunization. The clinic it is open now. Evening clinic immunization open. They gave an injection, and the patient suddenly became, stopped responding, and he is not. He's not crying, and there's a huge problem there. You're called. What are the things that go in your mind? What will you do? What goes in your mind? Is a DPT injection? It's a pentavalent injection. The sister gave immediately. The child, within 2 or 3 minutes, the child became did not respond. Is not responding, lying almost unconscious. So, what are the points which crosses your mind? Because we heard many things here. It's a very crucial thing that can happen to you, that can happen to you very rarely, but we will be discussing it in full depth about it. But I just want to know what are the possibilities which will cross through your mind. Ashwati, can you tell me what are the possibilities?
The anaphylaxis.
Okay, what else? Just now we have read something.
Vasovagal syncope.
Vasovagal syncope. Okay. Number 3. Anything else? It's a topic which is given as a side effect, hardly discussed, but is very, very important. Therefore, anaphylaxis, we will be discussing it in detail because it's very important for the pediatrician. Your consultants may not be knowing about it. It is very, very rare, luckily. That is why even if you have no knowledge about it, you can get away with it. But sometimes if it catches you on the wrong foot, it might be. There is something called hypotonic, hyporesponsive, HHR response, I think. I don't know. This is often written. But the problem is it's very important to diagnose if it was anaphylaxis or not. It's a huge problem because the moment you label it as anaphylaxis, he becomes contraindication for any further injections. Now, if you're giving a hexavalent vaccine, no pediatrician will give any of the immunization afterwards. Therefore, you have to differentiate between 3 important. There are many other differential diagnoses. One is, of course, anaphylaxis. The other is vasovagal syncope, very common. And 3 is hypotensive, hyporesponsive reaction. Now, we will be discussing in a full class about anaphylaxis. I will be sending the link to my video. And also, I'll be sending a PowerPoint presentation which contains additional information to this. And we will discuss it. But go through it. And my simple question is, if I ask Faris, how do you differentiate between forget the hypotensive, hyporesponsive event, HHE it is known as. Very little literature is there, and I will not blame you if you are not knowing about it. But how will you differentiate between an anaphylaxis and a vasovagal syncope? Faris,
BP for
BP fall. Ashwati, your second opinion, then Majida will give a third opinion. Ashwati?
Vasovagal syncope, it can be an immediate effect,
Hmm.
but anaphylaxis took some more time.
Okay, you're not to the point. What about hypotension? But that's what Faris is concerned.
Anaphylaxis also there is hypotension.
Vasovagal syncope? Okay, Majida, you tell me. This could have happened in any hospital which you worked. It could have happened in any injection you gave. This is even required for the nurse. You must know what to do. My job here is not just to tell you about 50 slides about AEFI. You must know to be a doctor at the bedside. You don't attend your classes. You don't come for the meeting and then you pass out with a diploma and become a consultant. And you don't know what happens if a sister calls you and says the patient has collapsed. This is a very, very terrific situation. The relatives will be after you. The nurse will panic. Even I have panicked. I have seen about 10 all the time. I have panicked. I am telling you very frankly. Now, my question to you is, how do you differentiate between an anaphylaxis and Majida? See, the answer is very simple. The moment the patient collapses and in front of you, all injection should be given either sitting on the mother's lap or lying down. Adults lying down or sitting. Sitting is also not a very, never standing, never on the mother's shoulder. The child should not be upright when you're giving injections. That's the number one mistake. Probably, Ashwati, your own child, Majida, your own child, when they gave the immunization, I don't know, did they give it when the child was on your shoulder or when the child is on your lap? Ashwati, can I answer? Can you answer? She's not. You can unmute and answer if you're there. All right. Now, what you do is, I'm not sure. Majida, what you do first is put the patient supine, raise the leg immediately. Now, a child with vasovagal endoscopy will recover within minutes. Both anaphylaxis and this can happen within minutes. Anaphylaxis is unlikely to recover within minutes. Vasovagal syncope, immediately he will recover. Put it supine, raise the legs. That's the first thing. Call for adrenaline. You may not give it, but call for adrenaline immediately and tell the dose. Now, when the hypotension virus can occur for both. Both anaphylaxis and hypotension can occur. The problem is you don't have the time to measure the blood pressure. It will be too late. You look for a rapid 3D pulse. When you look for a rapid 3D pulse, it can happen in both. Now we will discuss it further, this one. Now we are more concerned with AEFI. Anaphylaxis is a huge chapter which you should discuss. That's what I think. Okay. Now let me, oh, sorry. Okay, no, I think I will discuss this. Who else has joined? Mohsen has joined. Mohsen, you are there?
Yes, sir.
What happened to you? For the last 3 classes, you did not come. Even today, you did not come.
I went to home, sir, for a PSC NOC was.
You could have logged in from
Okay.
there. Am I right? You could have logged in from there.
Was through traveling. Sir.
Okay. Now, read it now. This is the answers. I think you read the whole thing in this slide. What are the reasons, how you classify the error? Okay.
Vaccine quality defect related reaction.
Yeah.
An AEFI that is caused or precipitated by a vaccine that is due to one or more quality defects of vaccine product, including its administration device as provided by the manufacturer. Example, failure by the manufacturer to completely inactivate a lot of inactivated poliovirus vaccine leads to cases of paralytic polio. Immunization error related reaction. An AFI that is caused by inappropriate vaccine handling, prescribing, or administration and thus by its nature is preventable. These include transmission of infection by contaminated multi-dose vial or reuse of disposable syringes and needles. Now, reconstitution error, vaccine reconstitution with the incorrect diluent. Injection administered at incorrect site. BCG given subcutaneously, rabies or hepatitis B vaccine given sub-Q, or DPT administered sub-Q.
Okay, now they are classified into vaccine quality defect. Immunization error. The moment you say immunization error, it has got tremendous medical legal problems. Remember that. Reconstitution error, infection also incorrect site. Okay. Now you read what's in the bracket alone.
Immunization anxiety related reaction. An AFI arising from anxiety about the immunization, example vasovagal syncope in an adolescent following vaccination. Anxiety may spread to community too at times. Coincidental events. An AFI that is caused by something other than the vaccine product, immunization error or immunization anxiety. Example fever after vaccination. That is temporal association and malarial parasite isolated from blood.
We read all this. Remember, immunization anxiety related, and he has talked about vasovagal syncope. Remember, vasovagal syncope is not always anxiety related. You understand? Many infants, what anxiety? They have nothing till the injection goes inside. The pain can cause a vasovagal syncope. Anything can cause vasovagal syncope. Okay, anxiety can cause vasovagal syncope. Therefore, you have to think about vasovagal syncope even in a 6-week-old child. Remember, when the pain can cause a vasovagal syncope suddenly. Therefore, it is not always due to anxiety. Okay. You can read the next one.
Which of the following is not a criterion for a serious AFI? A. Hospitalization. B. Persistent disability. C. High-grade fever without hospitalization. Cluster of cases.
You have not seen the power slide.
High-grade fever.
Okay, which is not a criteria for serious AEFI is now. First, we have said what are AEFIs. Now we are talking about the criteria for what is serious, what is mild, etc. Majida, can you answer?
Sir, high grade fever without hospital.
Yeah, okay. Now read it. Now read the answer, Mohsen.
C. Explanation. High-grade fever without hospitalization is considered a severe AFI, not serious. Serious AFI includes death, hospitalization, disability, clusters, or community concern.
Okay, now remember that there is something called this is a serious AFI. Most severe is considered more than that. I was a little surprised at it. Serious AFI is the number one, the most important thing. Includes death, hospitalization, disability, clusters, or community concern. But remember one thing which is very funny is that whenever you have an adverse event following an immunization, which is even what you call serious and not severe, you may have to admit the patient for observation for 16 hours. Therefore, then it automatically becomes a what you call a serious AFI. Now, serious AFI including death, hospitalization, disability, these are considered serious is considered more than a severe. Remember this. I don't know why it is so. Okay, can you read it once more for
serious AFI? An AFI is considered serious if it one results in death, hospitalization, or persistent or significant disability or incapacity. 2 occurs in clusters. 3 causes parental or community concern. Or 4 result in congenital anomaly or birth defect. 5 where the vaccine quality is suspicious.
Okay, now remember, serious is the topmost grade. All right. Before I stressed one thing to you to telling that in adverse events, only the timeline is important. Only if you give an immunization, I told you within 2 or 3 days, the child starts having vomiting and headache. You are sure it is not due to immunization, or after a week it happens. The parental concern is there, or the community concern especially is there. It becomes the topmost serious AFI, and you report the case. Remember, when you report like this, immediately what happens is if it is not a problem so far in the community, your senior, your MOAC will come and tell you, why in the hell are you creating problem? Your nurse will come and tell you, why are you moving against us? A nursing supervisor will come and say, why are you pointing a finger at us? Show it to them that parental or community concern causes serious AFib. I'm only reporting. It doesn't mean it's a cause. Why should you report it? Because after 5 days or 7 days, another 10 people are admitted. It comes up in the television. It comes up in the newspaper. The first question with the inquiry team will ask you is, who gave the immunization? Why did you not report? You can't say the medical officer in charge asked me not to report or the DMO asked not to report. When there is parental concern, things are not going properly. Even if you think it is not related even, there's only a timeline. You have to report it. Okay. Now go through the next. Can you read it?
A 14-week-old infant develops swelling of thigh extending beyond the knee after pentavalent vaccine. This is classified as minor AEFI, severe.
Mohsin has not seen the slides. Therefore, I think, Ashwati, can you help him?
So minor AEFI.
Well, it has crossed the joint. Okay, remember this. Answer is B, severe. It is not serious. It's not life-threatening or hospitalized. It is severe. Okay, read it. Can you read it? Majid?
Explanation.
Yeah.
Swelling extending beyond the nearest joint after DBT containing vaccine is a severe AEFI due to increased intensity, though not necessarily life-threatening.
Okay, remember that these are all basic things about immunization, Mohsin. If you miss your class, if you miss reading this, when you go for the exam, you can have serious problems. Okay. Now I will ask Majida to read the next one.
A cluster of AEFI is defined as A, one case of anaphylaxis in a vaccination session, B, two or more cases of the same AEFI related in time, place, or vaccine, C is any event causing parental concern, D is all AEFIs reported from a district in a month.
What is it?
Two or more cases of the same AEFI related in time, place, or vaccine.
Okay, you're right. Now, I want to tell you one thing here, that general attitude is whenever a patient develops any reaction like a vasovagal syncope or hypotonic hyperresponsive, the nurses and the hospital somehow want to push it below the carpet. So want the PA. അത് പേടി കൊച്ചു പേടിച്ചു പോയതാ. I mean, child became പേടിയുടെ കാരണമാണ് എന്ന് പറഞ്ഞ് അങ്ങ് വിടും. See, that is, they don't want to create a problem. They don't want to be reported. They think that the parents will think something is going wrong before when you are reported, and the hospital will get a bad name. There will be an inquiry by the DMO, everything. 9 out of 10, nothing will happen. In 1 out of 10, this can become a problem later on. Now, cluster is also, this is the 2 or more is the answer. Now, you can read it, severe AFI. What is severe AFI? Can you read it? Yeah.
Severe AFIs are minor AFIs with increased intensity or severity. Example, high-grade fever following pentavalent vaccination or post-DPT swelling extending beyond the nearest joint. They are caused when recipient's immune system reacts to antigens, adjuvants, stabilizers, preservatives contained in the vaccine. They are very rarely life-threatening, nor do they cause any disability, although there is some risk of morbidity. The patient may not be hospitalized and will not have sequelae.
Very important. I forgot to highlight this. I should have highlighted. They are not life-threatening. That's a very important point. Okay, they are not life-threatening, and they do not cause disability. If they cause disability, then it becomes a what you call above that severe, and then what is the one which is above severe?
Serious AFI.
Serious AFI. Now here they write the patient may not be hospitalized, but if it is hospitalized, then it becomes a serious AFI. Therefore, that rarely life-threatening. Patient's immune response. Therefore, if a patient has a swelling not crossing the joint, If he has a fever or 102 and it goes away, okay. But he has written high-grade fever, but they have not written the temperature. Okay. Now, read the rest.
Minor AFI is usually occur within a few hours of injection, resolve after short period of time, and pose little danger. Minor AFIs can be local reactions like pain, swelling, and redness, or systemic reactions, which is fever more than 38 degrees Celsius, irritability, malaise, etc., which can be managed with antipyretics and anti-inflammatory and resolved within 2 to 3 days. Cluster of AFIs is considered serious AFI. A cluster is defined as two or more cases of the same AFI related in time, place, or vaccine administered. A cluster usually occurs with a particular healthcare provider or a facility.
Okay. Now, if you have a cluster, two cases, you gave injection, the PRS, and the patient developed cellulitis, that is enough. Immediately report, stop the immunization, because it might be two cases enough. More than one is enough to call it a cluster. Okay.
11th question. Which of the following AFIs must be reported? A. Mild local pain after vaccination. B. Low-grade fever responding to paracetamol. C. Any serious AFI. D. Irritability lasting 12 hours. Any serious AFI.
Okay, the answer is obvious here. What are the cases of AFI that must be reported is a question which is very important. Therefore, when you write AFI, suppose you are asked a full question AFI, you begin by definition, which you have said, and then you write what are the cases to be reported, how do you classify it. You must know the headings very well. Now, what are the cases? You read it.
The following AFIs should be reported. All serious AFI, signals and events associated with a newly introduced vaccine, AFI that may have been caused by an immunization error, significant events of unexplained cause occurring within 30 days after vaccination, events causing significant parental or community concern.
All right. Here also, I would like to bring you to the notice two things. I should identified it. Any event causing significant parental or community concern, you should immediately implement it. You understand? You are sitting in a primary health center. You gave an injection. The child in the evening, had a convulsion, or you think that DPT following convulsion is very common. It's not something. The parent is very concerned. He's going to go to the hospital. He's going to create a ruckus. Immediately report it for your own sake. And here, occurring within 30 days, that also is little, but they say 1 week later, why are you reporting? No, remember these things, 30 days. And these are all series are causing significant parental or community concern also. This is important. It's not only all serious AFI, there are many other things which you should think. And this 30-day business also in the next is a little difficult. I think you'll have to timeline of reporting the vaccine. And what I want you to say is, if you want to read through it, you can read through it. What I want to suggest here is, we will be spending a lot of time reading it. Already 45 minutes have gone. Now, occurring within 15 days of immunization, encephalopathy, okay, occurring within 3 months. That's one vaccine-derived vaccine. VAP will occur within 60 days. Here they're written 3 months, vaccine-derived poliomyelitis, etc. Occurring within 12 months, BCG lymphadenitis. Not every lymphadenitis, but suppose it becomes very big and the patient is very unhappy, even within 1 year you can report. And there are no time limit to certain reporting. Death, hospitalization, unusual events that are thought later to immunization. For example, a patient you gave immunization 6 months later, running in the ward, he dies. There's a big ruckus about it. Probably it was a long QT interval. But there might be, don't jump and report it, but think about it. There is no time limit. Remember this. There were reportable adverse event following administration. This is what I want to point out. Somewhere before they have written 30 days before. Remember this. here they have written 30 days. But when it comes to timeline, they have even written no time limit. Okay. Keep it in your mind. I don't want you to read it because you can't remember all that. But there's no timeline. Therefore, if a patient after 1 month comes to you and says, Doctor, after immunization, 15 days later, he developed a convulsion, taken LP done, blah, blah, treated as meningoencephalitis. Now I think it is due to vaccine. You may have to report it. Okay, now. Okay, now you read it.
Who should be notified immediately after a serious AEFI is observed in a government outreach session? A. District collector. B. Medical officer of the nearest PHC or district immunization officer. C. State health minister. D. National polio surveillance officer. B. Medical officer of the nearest PHC
Yeah,
or
DIO means district as an immunization officer now initiates reporting and investigation. Okay, now you must know how to report it. Read this.
process of reporting adverse events. Most vaccinations in India are given through the government system through outreach sessions by auxiliary nurse midwives and sessions in health facilities. To make reporting simple and to get as many cases reported, health workers and medical personnel are asked to notify serious and severe AFIs immediately to the nearest primary health center medical officer or the district immunization officer. Private practitioners are also encouraged to notify AFIs similarly to the DIO.
Okay, therefore that's very important. You must know which cases to report, where to report. Okay, a district in a primary health center. You know why it is important to know this is the moment you call the primary health center doctor, he will tell you, Doctor, don't disturb me. You report to the immunization officer. When you talk to the immunization officer, he might say report to the DMO. Therefore, you must say, sorry, doctor, as per our guidebook, it is to you. It is become then onwards, it is his responsibility also. Okay.
Within how many hours must the PHC medical officer report a serious AFI to the DIO? Within 24 hours.
Okay. All right. Next.
The case reporting form includes all the following except A. Patient's basic details, B. Vaccine and session details, C. Full laboratory investigation reports, D. Brief clinical summary.
You are reporting within 24 hours. It's called the CRF, not chronic renal failure. It's case reporting form.
Brief clinical summary is not there.
That should be there.
So, sir, full laboratory investigation.
Yeah, you must see when you have to have a go at it, you must use your gray matter also. How can you have the full laboratory investigation? Are collected later during investigation. You are reporting in the first 24 hours. Now read it.
The MO at the PHC then reports the case in the case reporting format within 24 hours to the DIO, who has another 24 hours to verify the case and send it to the State Immunization or Expanded Program of Immunization Officer and the Immunization Division, Ministry of Health and Family Welfare simultaneously. The CRF gives only the most basic details of the affected person, vaccines and session details, and status of the patient, that is, brief clinical summary at the time of filling the format.
You are in a hurry, you are in distress actually because there is a huge event in your hospital. You are reporting it and people are accusing you. You can't be waiting for too many things. Therefore, you should report it. Okay. Within 24 hours. From there, timeline is important. Whom you report is important. This is the preliminary. Before this was the what is this called? Case reporting format. That is what the MO and the PHC then reports it. Then comes the preliminary case investigation form to the state and national level within. Sorry, the answer also came up. Okay, tell that. I don't know how that
The
happened.
preliminary case investigation form, along with the verbal autopsy in case of death, must be submitted within 10 days of notification.
Okay, autopsy of death must be 10 days is the answer. C is the answer. Now read through it. Okay.
The district AFI committee, when it meets, discusses all the case reports and records summarizes the findings of the investigation in the final case investigation form, and gives its opinion on the probable diagnosis. The FCAF is sent to the state AEFI committee and the immunization division within 100 days of notification. At the state level, the causality assessment expert of the state AEFI committee discusses all the reports available, gives a diagnosis, and classifies the case as per WHO classification. A proportion of cases causally assessed by the states are further causally assessed by the National AEFI committee.
Very, very important, because causality assessment. See, you are getting 5-mark questions from AEFI. The next is causality assessment. That's a short note. Therefore, you should know this. Finally, why do you report all that? Finally, you should find the causality assessment, sent to the AFA committee and immunization division within 100 days. There's a problem in this. You will see in the next 2 or 3 slides. Okay. Now, if you look at these slides, AFE detection, you have detected, you notified it, you reported it. I don't know what's the difference, notification, reporting. It is being investigated by the district data management. Causality assessment. Causality means you find out the cause, the feedback is given, and action is taken. That's how it is sometimes. And now they say there is a timeline for it, because very important, because if you don't follow the timeline, you can be in trouble. Therefore, you must notify on day 0. Okay. Within 24 hours, it should reach the medical officer on the case with reports to a district. He has only 1 day. The PHC doctor on a 1 day, whether it's a Sunday or Saturday, 24 hours, he should report. Now, district decision on investigations inform state. What about it goes to a DMO office? The DMO will take a vehicle and come to your place. She might most probably investigate or give you a phone call. She's supposed to do an investigation, and then the reports, whatever she wants to report, to 48 hours. Therefore, you have the medical or PHC doctor has 1 day, he has 2 days. Now, preliminary investigation, district reports to state, day 10. The district should report to the state by day 10. Now, here is a problem. The final investigation, the preliminary investigation on day 10, the final investigation on day 70. That's what they have written here. And the causality assessment is on day 100. But when you write the final investigation also, I think there's a problem here how they're written. Therefore, by 100th day, that is 3 months usually, the final causality should be there. This is a little doubtful investigation. Now, may I ask you a few questions here? Go ahead with it.
Which of the following is not a part of AEFI investigation? Review of cold chain maintenance, interview with caregivers and service providers, genetic testing of the child, collection of hospital records.
What do you say?
Genetic testing of the child.
Yeah, genetic testing. Right. Okay. Read it.
While clinical and epidemiological investigations are done, genetic testing is not routinely part of AEFI investigation unless specifically indicated.
How do they investigate? Now read it now. Just read it fast. I think Ashwati is there. Ashwati can read it fast.
Investigating adverse events following immunizations. As soon as the AEFI is reported, case investigation begins. The preliminary case investigation format PCIF acts as a checklist and records the details of the investigations done with relation to the case. The investigation involves verifying personal details, vaccines, and program details, a clinical examination, interviews with the treating physicians, caregivers, service providers, volunteers, and etc. To understand the sequence of events, an epidemiological investigation is also conducted. The cold chain and the vaccine transportation conditions are studied. Hospital records, laboratory test reports, and other relevant documents are collected. In case of death, postmortem is recommended. Verbal autopsies format have been designed specifically for finding the cause of AEFI deaths. These forms should be used whenever a death is highlighted to be associated with vaccine. These, along with the filled PCIF, are submitted simultaneously to the state and the national level within 10 days of notification. Whenever required, experts of the district or the state AEFI committees are requested to participate in the investigation.
Okay, now we went through very fast these things. They see so many things once you report it. Once you report it, so many things have to happen. You know, the district medical officer, the state health committee, so many interviews. So what happens is there is always a pressure on you. Why in the hell did you report it? That's always happens. But therefore, you have to make a very positive. Am I going to report or am I not going to report? If it's just a vasovagal syncope, forget it. But if anything beyond that, better report. If there is some problem occurring in the community, you can sense it, better report. The immediate response of your seniors, why are you causing problem? Your nurse will come to you and say, doctor, why are you treating us like criminals? But this is the law of the land. You have to report. And if you don't report, if after 1 month there is a problem, then you will be the person primarily responsible. This is a foolish question, but still I will take this. Ashwati, read it.
Postmortem examination is recommended in cases of AEFI related.
This is how can you do a postmortem on a local abscess? Only in death you can do it. But what is important is what I wanted to show you is verbal autopsy is used if postmortem is not done. Now I just want to tell you one thing. In one of the question papers, they have asked what is verbal autopsy. There's a mechanism to do it because postmortem is no. Whenever there is an AEFI, you go and do a verbal autopsy. How to do it is there. Therefore, you must read something about verbal autopsy and be ready for a short note on it. Because you may go for examination, they may ask you no other question from immunization except verbal autopsy. How to do it, I have not enlisted. Let me see if I get time, I might put it up later on. Therefore, note it down because when you go for exam, anything can be asked for immunization. Okay. Can you read what? Yeah.
Hospital records, laboratory test reports, and other relevant documents are collected. In case of death, postmortem is recommended. Verbal autopsies formats have been designed specifically for finding the cause of AEFI deaths.
See, actually, if you look at our what they call TV and all that, they will say they are going to do autopsy after unexpected death. Therefore, now the problem is, and even the medical director or the DHS will say the same thing. Remember, if it is an anaphylaxis, I don't think there will be any person finding in it. If there is a long QT interval, autopsy is not going to show anything. Therefore, these verbal autopsies might give you some idea what it is. Autopsy means there's a format for that. Anyway, read it next.
Who conducts a causality assessment of AEFI cases? Option A, the reporting pediatrician. B, district AEFI committee alone. C, trained experts at state and national AEFI committees. D, private laboratory. C, trained experts at state and national.
Yeah, this is very important for you to understand. The moment this happens, and you started reporting, and such this is a major event when you are in a health center or anywhere, even in a private hospital. You understand that even in a private clinic, there are many pediatricians who have been giving immunization for ages. And suddenly one patient develops a reaction. When they go through, they stop giving it. In fact, one of the pediatricians in our hospital, coming to hospital, has done it. He was making huge money by giving immunization, about 20 to 30% of his. But one patient developed severe reaction, and then it made him stop giving it. Therefore, the causality assessment is done by trained expert at state and national AEFI, not the initial reporter. Remember this. You may be a very senior consultant pediatrician at the place. The reporter or the channel will come and ask you, doctor, what's the cause? Tell them that the cause in such a case has to be given by law by the National AEFI committee and not you. They may tell you, doctor, you are a pediatrician who gave immunization and you still don't know the cause of it. You must still tell them, I am not authorized to do it. That's the first answer you should know. Whoever you are, even if you are the DMO, you are not authorized. Only the committee alone is authorized because they're very sensitive and important. Now, next question.
Causality assessment should be completed within how long after receiving all records?
Okay.
See 1 month.
1 month. All right. Causality assessment is not reporting. They should record all the records and then find out and say that this immunization given was the reaction was because of this problem, or it has got tremendous significance. Now, what they have written is IAP guidebook on causality assessment is conducted within 1 month of the receipt of all reports. Now, this is what happens sometimes in the purple book on vital matters. It can be for me, they have written 1 month assessment. Where you said 1 month, Doctor, who said this? Ashwadi, yeah?
Yes, sir.
Okay. Yeah, you opened the book and said, or what is it? Yeah, see,
Sir,
wrong
the PDF is
PDF which I sent it to you, and therefore you are opening the PDF as I am. Yes, okay. Now this question here is given 1 month. You are right. Your IP guidebook, and if you look at it, the causality assessment should be completed. Okay. Now look at it here. Read it. You are right, probably. Causality assessment, mind you, I told you is a short note. Therefore, you should know about it clearly. Read it, Ashwadi.
causality assessment.
Yeah.
Causality assessment is the systematic evaluation of the information obtained about the AEFI to determine the likelihood of the event having been caused by the vaccines received. It should be noted that causality assessment is not the responsibility of the reporting pediatrician. The causality assessment is conducted at the state and the national levels by trained experts in the AEFI committees within a month of the receipt of all records and the reports of AEFI case.
Okay, you're right in that. It's a systemic evaluation information obtained to determine the likelihood, okay, of the vaccine have been caused. The assessment is not even conducted at the state and national level, not even at the district level. Sometimes it goes to a national level by trained experts in AFMT committees. Therefore, it will be professors of a big institute like All India Institute or PGI Chandigarh who will be sitting as a chairman of this. But remember all this. Therefore, it is not a small thing. If they take it up, then they take it up very seriously. But the problem is here, they have written within a month, causality assessment as a state and committee within a month. Look at the timeline which we discussed. Causality assessment day 100, 3 days. This is what happens sometimes. It is a difficult question to answer. Many times the IAP guidebook gives two different assessment, but I think within a month maybe the causality is conducted by the state and national by trade within a month. Assessment is done. Okay, all reports. Probably the report is given, the timeline is within 3 months. This is a long time, more than 3 months. Therefore, there are conflicting reports in that. I don't know which you will answer. Okay, now next.
The final case investigation form must be submitted within how many days of notification? See 100 days.
Yeah, therefore the causality assessment can be done, but probably they should have done it the final, I don't know, 1 month to 3 months. They are waiting for the minister to agree to it. I don't know. Anyway, it is division within 100 days of there also is there. See, the opposite is there. 2 slides ago, I showed you something. Here, read what is given here.
The district AEFI committee, when it meets, discusses all the case reports and the report summarizes the findings of the investigation in the final case investigation form and gives its opinion on the probable diagnosis. The FCIF is sent to the state AEFI committee and immunization division within 100 days of notification.
Okay, therefore, this is, I am a little confused about it. Probably 1 month and probably 3 months. Both are written about it. Okay. Now, when do you start looking for a parental assessment? Okay. Can you
Which of the following is the criteria for causality assessment? parental education level, biological plausibility, cost of the vaccine, number of vaccines given in the session. B,
What's it?
biological plausibility.
Yeah, biological possibility. Plausibility is the what do you mean? The criteria for this is very important. Causality assessment. What is the criteria you take after? Criteria include, read it.
Criteria include temporal relationship, biological plausibility, strength of association, consistency, specificity, and alternative explanations.
There's a big chart in it which I did not include in it. It is there. The table is there, but it's a little confusing. Remember that if I have given something today, injection, and 3 days later the patient develops a fall and has a head injury, causality assessment can be used. It could have been an atonic seizure because of that. Remember, biological plausibility is also there. You give a live vaccine today and measles, three children, all of them develop measles. Then it's a biological plausibility. Therefore, you will have to look for it. Now, strength of association and consistency, specificity, and alternate explanation. Now, remember, biological plausibility is a temporal relationship. How long? Now, we said that even lifelong it can be. See, if I give OPV today, and after, say, 90 days or 80 days, he develops a paralysis, it can still be considered as a biological plausibility because OPV is known to cause vaccine-derived poliomyelitis, I think up to 60 days, sometimes up to 1 month. Therefore, you don't take up a cause. You see, once you take up causality assessment, it's a huge you report it. It is up to the district. He reports it further. He may not take it up for assessment of causality assessment. He might think, okay, this is nothing. You gave an injection. There was a spreading cellulitis. Most probably it is due to infection. He may take it up or he may not take it up. But what are the criteria by which he take it up for causality assessment? You have to understand. It's different from reporting. Remember this. Reporting criteria is something else. Causality assessment is something else. Okay, read it.
Criteria for causality in the causality assessment process include the proof of temporal relationship, biological plausibility, strength of association, consistency of association, specificity, definitive proof that the vaccine caused the event, consideration of alternative explanations, and prior evidence that the vaccine in the question could cause a similar event.
Okay, it's self-explanatory. Okay, what is it? Now comes the final verdict. You are giving the verdict. Okay. Okay, read it fast.
An AEFI is classified as consistent causal association under WHO
Classification. Okay. What happened?
which subcategory applies if the
There's a break, Ashwati.
A, A1
Majida, can you read it? Because Ashwati is breaking.
An AEFI is classified as consistent causal association under WHO classification, which subcategory applies if the reaction is due to a non-property of the vaccine. A1.
Okay. That means the verdict is given. Consistent causal association. Okay. Vaccine product related as per published literature. Example of febrile seizure after an MRI. Okay. Next is what?
A child develops sterile abscess after DPT vaccine. Investigation reveals the vaccine was frozen during storage. This is classified as A3. Improper storage freezing is an immunization error, hence classified as A3, which is immunization error related reaction.
Okay, I didn't put I put this. If A3 means immunization error, then the hospital as well as the nurse gets into serious trouble. Remember this. And you have reported and your own nurse has got into serious trouble, there will be a lot of problems for you. But if you don't report it and tomorrow they come to investigate and this has been revealed, you will be in serious trouble than the nurse because you covered it up. Okay.
An AEFI with temporal association but insufficient evidence for causality is classified as B1, sir.
Okay. Read it.
B1 indeterminate, temporal association present but evidence insufficient, may be a new signal requiring further study.
Next.
An event that is clearly unrelated to the vaccine but occurs after immunization is classified as
What?
C.
Unrelated to the vaccine, but occurs after immunization. Say you give immunization, he develops a malaria, he develops typhoid fever. Therefore, it is
sir.
under C. Yeah? Okay. Class. Therefore, B is what is B? What is C? You should know. Inconsistent with causal association. It's a coincident event. Okay.
Coincidentally.
You were just harboring the malaria. You came there. You got it. That's it. Okay. Next.
An AFI case where information is insufficient for classification is placed in which category? D, sir. Unclassified.
Okay. This can be therefore this is given. Can you read it now from top to bottom? The
Causality
top bottom
assessment.
is, see, the major, this is important. A is what, B is what, C is at least that much you must remember. Then you try to remember what is given below. Okay.
Causality assessment classification. A is consistent with causal association to immunization. A1 vaccine product related reaction as per published literature. A2 vaccine quality defect related reaction. A3 immunization error related reaction. And A4 immunization anxiety related reaction. B is indeterminate. It includes B1 and B2. B1 temporal relationship is consistent, but there is insufficient definitive evidence for vaccine causing event, maybe a new vaccine linked event. B2 is reviewing factors result in conflicting trends of consistency and inconsistency with causal association to immunization. C is inconsistent with causal association to immunization, that is coincidental, underlying or emerging condition or conditions caused by exposure to something other than vaccine.
Okay, remember this is how the causality assessment, you must know what are the patients who are criteria, what's the classification. This you must try to remember. Remember that at the end, how many days later it is done, who should do the causality assessment, who should give the report. For these are all from points in writing a determined. Remember, it's defined when adequate information is available. Sometimes adequate information may not be available. For example, patient is given the vaccine and the lot number is not noted down, and after 3 days you don't know which vaccine was given. These are all problems. B1 is a potential signal and may be considered for investigation. Indeterminate. Therefore, further investigation may causality assessment and classification is very important. Anyway, this is again related, the same thing which is given here. Okay, that's over. Now, can you say this, right?
What is the role of district AEFI committee? To conduct national policy changes, to discuss case reports, complete FCIF, and give probable diagnosis, to manufacture vaccines, to train medical students only. B, sir.
Okay, see, discuss case. This is what happens. The others are so easy, therefore you know which is right. But I'm a little surprised that they have to give a probable diagnosis. Remember, okay, remember.
Okay, sir.
Okay, there we again it. Now go to the next one. Adverse have been formed in all district and can you read the second paragraph also? Read it very fast.
The adverse events following immunization committees have been formed in all districts, states, and at the national level. The responsibility of the AEFI committee are to strengthen AEFI reporting at all levels, ensure maintenance of national policy and standards, ensure prompt and thorough investigation of serious or severe AEFI, carry out periodic review of AEFI for trends of non-serious AEFIs reported through the Health Management Information System, routine immunization reporting, responding to the media and community concern to allay fears regarding vaccine safety, ensure high standards of AEFI surveillance to ensure that no serious AEFI are missed, and recommended changes to the immunization program for ensuring vaccine safety.
Now, I would say that a very important point here would be respond to the media and community concerns. So when you are, if you have given in a primary health center, you will be the target. You tell them, no, the adverse AFI is supposed to respond very clearly. Read only what is given in the bracket. We have
The
said
district
that.
AFI committee, when it meets, discusses all the case reports and records, summarizes the findings of the investigation, the final case investigation form, and give its opinion on the probable diagnosis. The FCIF is sent to the state AFI committee and the immunization division within 100 days of notification.
I think they arrive at a final causality within 1 month, but then probably they take another 2 months to give the final notification. Yeah, how did the PRS hospital, whom should they report?
Directly to the Prime Minister office, to the nearest urban health center or DIO. To the nearest urban health center or DIO, sir.
Yeah. I'm not too sure. If you are in PRS, you will report to a DMO office or a DIO, District Immunization Officer. Okay. They just read what is given in the bracket.
AFI reporting from private sector will provide vital information on the safety of new vaccine in India. In rural areas, serious AFI occurring in the clinic of a pediatrician should be immediately reported to the medical officer in charge of nearest PHC or other health facility.
Normally, this is never done. Okay. People try to push it under the carpet. But the problem is then you are in danger. That's the only thing I would say that. Okay, next.
In the urban areas, it should be reported to either the medical officer in charge of near urban health center or to the DIO. By all channels, the information should reach DIO as soon as possible.
Let me tell you one thing here. Please don't call and ask, should I report? You understand? The answer that will come immediately to you is you need not report. In the Gulf, when we were working, we told all these problems. We had a reporting form on the net. Do we have a similar one here? Can we report online? Who else is there? Faris is there or gone? What about Ashwati? What happened to Gopika today? Gopika is on duty? No. Hello? Majida, is Gopika there? No.
No, sir.
Okay, she's not on duty and she didn't come also. Mohsin is there or gone? Only Majida and Ashwati are there, I think. Okay, this is the problem. Faris, you are there? I can't see on the. Okay. All right. Now, my question was something else. What was it I'm asking? In PRS, is there a channel which you report? Okay, what is this?
What is the purpose of idserve.org? To sell vaccines online, to report non-communicable disease, to conduct infectious disease and AEFI surveillance, to provide vaccination certificates. For C, option C, sir.
Okay. IP related platform for such. Therefore, there is a platform. You understand. This is very, very good. I didn't know about it. I don't know how many of your consultants know about it. The idea about this is the moment you report, you are safe. Don't ask anybody whether I should report. If it is coming, go through the book, go through this presentation, your presentation. If it is to be presented, some problem is occurring, report it. And then tell the medical officer in charge that I am reported it. He may say, why the hell did you do it? You say, sir, as per the rules, we have to report it. That's it. And what happens? Next question.
When a private practitioner reports in AFI via idserve.org, real-time alerts are sent to all except IAP AFI Surveillance Committee, State TPA Officer, Nodal Person MOHFW, World Bank Health Representative. Option
Actually,
D,
they should
sir.
have World Health, WHO should have been. World Bank, they said, I don't know. And normally WHO representative is there. We till recently, Dr. Prathapan was there, very active, whom everybody, even the medical colleges used to take second and third opinion. But what's the answer here?
Answer D, sir.
Yeah, World Bank. Therefore, what you mean is that the moment you write on it, therefore there might be a form, fill it up, do it in this also. Because when you do it, automatically the state EPI officer, nodal officer, everybody will get the report. Remember, they try to avoid. If you call them, they might tell you, look, doctor, no need, I will come and find out. Because the whole thing is a huge job for them. Therefore, if you think it is serious, just report it. Now, you can be asked a short note on ID side. The IAP is doing a fantastic job, I would say, doing this. Read it.
Online AFI reporting platform for private practitioners. IDserve.org is an infectious disease surveillance and AFI reporting system developed by IAP. The objectives of IDserve are to develop an early warning system for pediatric vaccine preventable diseases in India, to generate data on burden of vaccine preventable disease in India, to generate data on serious AFI in India.
So once I think we have this, okay.
When an AFI case is reported on IDServe, real-time notification is sent to IAP AFI Surveillance Committee, the state TPA officer, and to the nodal person in MOHFW, Government of India. Subsequently, the government authorities will take over the investigation of the case.
Right. Therefore, the moment you report, you are safe. But remember one thing, please do it in the form also. Okay. You may not find many of our doctors are doing it, but it is at their own peril, at their own risk if you don't report it. See, whoever advises you not to report, he's not going to get affected. You are going to get affected if it is not. Now, we have finished this presentation. The cold chain also we will look at it. Therefore, I'll stop sharing this this one here. Anju, you are there?
Yes, sir, I am here only.
Okay. I didn't know when you joined. What I wanted is anyway, they say it is now I have to go back to the desktop and let me see desktop, because we have been discussing cold chain also. And what I found out, there are many practical points in this, is it not? You report cases there, doctor? Do you report cases there? Anju?
I mean, yes, sir. The original problem of AEFA is exactly what sir said. Actually, we get minor AEFAs and all, and as sir was telling, we do not take much interest in reporting because it is a huge, humongous effort to fill the forms, and they will come and immediately blame the JPHs, and they are continuously, it is not a fact-finding type of thing which usually follows. But definitely, I have seen many these thigh abscesses following DPT vaccination and all. We usually think about. I have taken measures to report at least two of them, sir. That is what exactly is happening, and I have not yet seen a severe AVFI or serious AVFI yet, sir.
Thank Lord, but you can't be lucky all through your life, you know. You know that.
You are correct, sir. You are correct, sir. Thank you, sir. Yes, sir.
You can see the screen now, cold chain. Can you see the screen?
Yes, sir.
Okay.
Yes, sir.
1 minute, 1 minute. Now we will talk about MCQs in cold chain right now. You might think these are peripheral elements because they contain very, very practical points. And let me tell you one thing, the purple book has given the best. We in our MD students did not know anything about it. They have covered the topic very well. I don't know about Piyush Gupta. I didn't look at it. OP Guy and Nelson also doesn't cover it much. And every point is very important from the practical point of view. And questions are asked. You understand? Cold chain questions are asked. And okay, now we will go through it. We have only about half an hour. We will finish how much is possible. Can you read it?
What is the primary purpose of the cold chain in immunization? Option A, to reduce vaccine costs. B, to ensure vaccines are administered on time. C, to transport and store vaccine within the recommended temperature range. D, to improve vaccine efficacy through freezing. Answer is C, sir.
Okay. Okay, read it fast.
The cold chain ensures vaccines are kept within the recommended temperature range, that is 2 to 8 degrees Celsius for refrigerated and minus 15 to minus 25 degrees Celsius for frozen from manufacture to administration.
All right. Dr. Anju, you're still there?
Yes, sir.
See,
Yes, sir.
when I was in UAE, this was a problem. Even in Oman, there was a problem. Because I was HOD at one department, we went to a meeting. I stood up and said, this is the problem. When we report, our seniors don't like it. Now, afterwards, the ministry took it up very seriously. And what they did is especially in UAE, they put up a website like this. Now, the moment you report it, your mobile will ring. The first thing they tell you is, thank you, Dr. Padmanabhan, for reporting the case. First thing they tell you. And he gives his name and says, I will take action. He's the immunization officer. And then they will periodically send you the reports of what is going on. And they will contact a district medical officer, everything, and investigate. Therefore, we are not put in difficulties. I found it very, very effective. Here, the problem is the person who reports does not get any report back after the investigation. That's a problem which I think is happening here. But now they have produced a website. Did you know about it, Dr. Anju? There's a website, the last slide in the previous one.
No, sir. No, sir. While you were telling, I just Googled and the website is very active, sir. I just recently only know about these things. Knew about these things.
See, the thing is, Dr. Anju, you are a very, very active member of the IAP. You did know. Then how do you expect the others to know? Our students I don't think they are reporting in PRS hospital. Our consultants have not told me about it. Only when I went through this, I came to know about it. All right. Therefore, these are our new junior doctors should report on it, write the form, then only ask for the form and say, I have already reported. Then nobody can tell you no. Okay. Okay, fast.
Which of the following is not a component of the cold chain? A, personnel. B, equipment. C, vaccination schedule. D, procedures. C, vaccination schedule.
Okay. Read it.
The three main components of the cold chain are personnel, equipment, and procedures.
Read what is, there's definition. You can be asked the definition and the main components. So read it because it's important.
The cold chain is the system of transporting and storing vaccines within the recommended temperature range from the place of manufacture to the point of administration. It has three main components. One is personnel, two, equipment, three, procedures.
Yeah, from the place of manufacture to point of administration. This is very important. The main problem arises there. The health personnel go and keep the vaccine in their home. They keep it in the fridge. They may keep it in the flask and the ice may melt off. These are all huge problems. Procedures, okay? Just read what is in the third line. So equipment is?
In equipment, it contains storage devices and temperature monitoring tools. Personnel contains staff training. Procedure contains storage protocols.
Okay.
What is the recommended temperature range for storing most refrigerated vaccines? B, 2 to 8 degrees Celsius, sir.
All right. I think you have the answers in front of you. I think, okay, the optimum temperature for refrigerated vaccine is 2 to 8 degrees centigrade. I'm going through this. Okay.
Frozen vaccines should be stored at which temperature ranges? Option A, -2 to -8 degrees Celsius. B, -10 to -15 degree. C, -15 to -25 degree. And D, -25 to -30 degree. C, -15 to -25 degrees.
Which vaccine is stored there usually? Can be stored there. Most of the vaccine cannot be frozen. Remember this. You freeze it, you had it. The vaccine is gone. Which vaccine can be stored in the frozen vaccine? In our oral for our MD, the commonest question was this: in which chamber will you keep it? What you keep in the top of the fridge? What you keep in the middle of the fridge? What you keep in the door? These were the commonest questions, and these were never there in most of the books at that time. But this purple books gives it beautifully. Anyway, you are right actually. Required minus 15. OPV is the one which we normally have, which can be frozen. You understand? But it can be kept at the top of the fridge also. We will come to that. Read it. Read what is
About the optimum temperature for refrigerated vaccines is between +2 and +8 degrees Celsius. For frozen vaccines, the optimum temperature is -15 to -25 degrees Celsius.
okay. Okay, read it.
Which of the following vaccines is sensitive to light? A. DPT, B. Hepatitis B, C. Measles, D. Typhoid conjugate vaccine. Sir.
What is it? Ashwati, you are there?
Yes, sir.
Okay, tell me. I think Amal also joined in between. Amal is there or what? No. Only you two are there or anybody else? Faris is there?
Yes, sir.
Okay. But Faris, now you read now. Which is the vaccine? Which of the following vaccines sensitive to light?
I think hepatitis B.
Anyway,
Typhoid
see, in
conjugate.
MCQ, there are two things. If you don't know the answer, one is you leave it, other make a very intelligent guess. When you make an intelligent guess, you find out that all the vaccines are bacterial except measles. But that might be the answer. Answers, look at it. Read it.
Measles, MMR.
Yeah. Who's reading? Majida must have got tired. That's why I asked Faris to read. Okay.
Measles,
Explanation: measles, MMR, BCG, varicella, rotavirus, HPV, and other all are light sensitive and must be protected from sunlight and fluorescent light.
Okay. All these are live vaccine except HPV. Human papilloma virus is, I don't think is a live virus. Therefore, remember it like this. You can't remember. Light sensitive and must be protected from sunlight and fluorescent light. Remember this, not only temperature, but also light. That remember, read the one which is bracketed.
BCG, measles, mumps, and rubella, varicella, DTP, containing vaccines, HPV vaccines, and rotavirus vaccines are sensitive to strong light, sunlight, ultraviolet, fluorescent, and exposure of these vaccines to light should be avoided.
Very important. Okay, it's not only the temperature, but it's also the light. Most of them are live vaccine except HPV, I think. Okay. Read it fast.
Which of the following is key reason for maintaining the cold chain? A. To reduce the number of vaccination. B. To prevent vaccine wastage and maintain potency. C. To allow vaccine to be stored at room temperature. D. To increase vaccine shelf life indefinitely.
What's the answer? Okay, Majida, can you give the answer?
B, option B.
Okay, answer B. You read it now.
Explanation: maintaining the cold chain, prevent the vaccine degradation, wastage, and ensure immunization effectiveness.
Okay, that's right. Next one.
What percent of healthcare workers have been found to expose vaccines to improper temperature?
Well, this is a hazardous guess. So the answer is 7 to 37%. Maybe one of the studies are showing it. I've also felt it. Many of the healthcare workers, when they go out in the field for immunization, from morning to evening they give, and then they don't go back to the health center. They take the box with the vaccine to their home. Many of them don't have refrigerators. When we were in the health centers. Therefore, especially for OPV, there's a huge problem. Okay, now read it. Read the next. What is bracket?
Different survey studies and site visits have found that about 17 to 37% of healthcare providers expose vaccines to improper storage temperatures. Refrigerator temperatures are more commonly kept too cold rather than too warm.
Okay. This is what happens in many places. They are not kept in a proper place. Okay, now go to the next.
Which vaccine must be protected from freezing? OPV, BCG, DPT, yellow fever.
I don't understand that.
DPT. Explanation: DPT, hepatitis B, TT, and other pertussis containing vaccines are freeze sensitive and must not be frozen.
But does it mean that BCG can be frozen? I'm not too sure about it. And yellow fever can be frozen. OPV can be frozen, is it? I'm not too sure about the answer. Let me see what's given next. Freeze sensitive vaccine. Read it, okay? At least what is highlighted. Heat sensitive, damaged by freezing. What are they?
Freeze sensitive vaccines are DPT, pertussis containing hepatitis B, typhoid, meningococcal, Hib, pneumococcal, HPV, rabies, and JE inactivated.
No. See, the freeze damage by freezing is only DPT, DT, TD, and TDAP, and hepatitis B. The others are not damaged by freezing. Typhoid, HPV, rabies, they are not. It is not written as damaged by freezing. They were a little difficult for me to understand. Therefore, I thought that only OPV is not damaged. It looks like which is in this, if you look at it, if you look at conjugated vaccine, if you look at typhoid conjugated vaccine, meningococcal vaccine, HPV, rabies, GA, they have not written it as freeze damage by freezing. You understand? And they are all heat stable, heat sensitive, they are heat stable. What do you mean? Even if it is a little hot, it is maybe only OPVs. If you will have to think of which vaccine. I thought it's a live viral vaccine, which are this one heat you can freeze, but here is conjugated vaccines which they have written. Anyway, you will have to read it and mug it up, I think. Okay, now right. Okay, say that. Can you read the line?
Which equipment is used for bulk storage of OPV at state stores? Cold box.
The
Freezer.
OPV at state stores, you have to keep it for 3 months. 3 months is the usual time for which a vaccine is kept. Therefore, you have to have freezers. Okay, remember this.
Explanation: walk-in freezers maintain -18 to -20 degrees Celsius and are used for bulk OPV storage and freezing ice packs.
Yeah, here they are writing that in freezers you keep only bulk OPV and freezing ice packs. These freezing ice packs are used for transport. Okay, it's a question. And remember that huge. This is, you can read it now. You can read vaccine storage completely. Equipment. We are coming to equipment actually.
Vaccine storage equipment can be classified into electrical and non-electrical equipment. Electrical equipment consists of walk-in freezers, walk-in coolers, deep freezers, ice-lined refrigerators, and the domestic refrigerators. Non-electrical equipment includes the cold boxes and vaccine carriers. Walk-in freezers. Walk-in freezers are used for bulk storage of OPV vaccines, and also for the preparation and storage of frozen ice packs at state stores. They maintain the temperature of -18 to -20 degrees Celsius.
Okay, therefore in the walk-in freezers, I thought in walk-in means it's small. No, it's a huge. Freezers are very big in the state unit. It is there. Okay. Next is read it. You can't read it? Hello? I can't hear you.
What is the temperature range maintained in a walk-in cooler?
Okay. What is it? A little difficult to know this. What is walk-in freezer? What is walk-in cooler, etc. 2 to 8 degrees centigrade used for bulk vaccine storage as stated. Freezer, it will be, the temperature is minus 18 to 20, while cooler, it will be 2 to 8 degrees centigrade. Okay. Remember that I used in which okay, read
Which
it.
of the following is a feature of walk-in coolers? A. Manual temperature recording only. B. No alarm system. C. Audio visual alarm for temperature deviations. D. Operates only on solar power.
Following the feature. Answer is
Walk-in coolers have LED or LCD
audio
displays.
visual alarm for temperature deviation. It is there for walk-in coolers. Okay. They are okay. Have LED, LCD displays, digital temperature recorders, and audio visual alarms for temperature excursions. They were walk-in coolers, walk-in freezers, usually kept in the district level. All right, you may get a photograph of it. How much? Okay.
How much buffer stock do walk-in coolers or freezers maintain? Around 25%.
Yeah, right. They're 3 months, 25%. 3 months is you have to keep all the time. Buffer stock should be maintained. Otherwise, you should not have a shortage of vaccine. That becomes a very bad, huge negative mark for the DMO. 3 months, therefore 25% of the total. How much do you give vaccination every 3 months? Out of which 25% you should be having it at home. Now we will talk about something about walk-in coolers, what is read what is in the bracket.
These cold rooms are typically controlled between 2 and 8 degrees Celsius. It has digital light emitting devices, light crystal devices, temperature display and temperature recorder. It is fitted with an audio video alarm system to warn of high or low temperature. These are used for bulk storage of vaccine at state and regional stores. Walk-in coolers or walk-in freezers stores 3 months of requirement of vaccines and 25% buffer stock for districts they cater.
Now, when I heard the term walk-in, I thought that's something which you carry with you. No, it is the bulk storage of vaccine at the stage and regional center for at least 3 months. And the freezer is used for OPV and the making the ice packs. That's all. All of the vaccines are stored in walk-in coolers. Okay.
What is the typical temperature maintained in a deep freezer under the immunization program? In deep freezer, A is minus 10 to minus 15, B minus 15 to minus 18, C minus 18 to minus 20, and D is minus 20 to minus 25.
May be difficult. It is minus 18 to minus 20. I don't know whether you should know so much details. It's good if you know. If you have doubt, it's always better to refer and then say, because it's already given. Minus deep freezers, minus 18 to minus 20. Okay. Degrees used for storing OPV and this one. Now, what's the next?
In an ice-lined refrigerator, where should the most heat-sensitive vaccines be stored?
Ice-lined refrigerator. What is ice-lined refrigerator? I'll come to that. I think it was in the previous slide. Normally in our fridges, which we used to buy, the coolest is the top compartment because we had the freezer at the top. Nowadays, fridges are coming with freezer at the bottom also. But in ice-lined refrigerator, the coolest is the bottom one. Okay, that's what they say. Read it now.
The bottom is the coldest part in an ice-lined refrigerator. Therefore, heat-sensitive vaccines like measles, BCG, OPV are stored here. This is opposite to domestic refrigerators.
Just one word about isoline. Okay, read about isoline refrigerator. What is that?
Iceland refrigerator. These types of refrigerator are top opening and front opening. Inside the Iceland refrigerator, there is a lining of water containers, ice packs or tubes, fitted all around the walls and held in a place by frame.
Okay, that is a double insulation. Even if the temperature, if the current goes off, these ices will maintain for some time. There's an ice pack around the all around the chain. The problem with that is the vaccine should not come in direct contact with them. Okay, now that may be shown up. Okay.
In the Iceland refrigerator, where should the most heat-sensitive vaccines be stored? Bottom is the coldest part.
Yeah, answer also came with it anyway. Now next question is,
how much electricity does an Iceland refrigerator needs daily to keep vaccines safe?
it will be difficult
6
for.
hours.
Therefore, what it means is how much can the current go away? You understand? Above which, if it goes more than this hours, you will have to transport the vaccine to somewhere else. That is what it is written. It is C. Okay.
8 hours.
8 hours you can keep it. All these points are important when you are in a primary health center where you are storing vaccine. These knowledges may be important. I'm not too sure that they will ask you unless you have an oral. Since you don't have an oral, in our MD examinations at that time, the vaccine storage was a very important point, but they don't used to ask so definite. They just used to ask, "What's this Iceland refrigerator? Do you have it in your hospital? Do we have it in a hospital?" If I ask you, Ashwati, have you gone into that room and looked at the fridges which is there in our hospital? Please go and find out yourself. Okay. Okay, now read it now.
While the refrigerator is operating, the water in the containers freezes, and if the electricity supply fails, the ice lining keeps the temperature inside the refrigerator at a safe level for vaccines. It can keep vaccines safe with as little as 8 hours continuous electricity supply in a 24-hour period. Hence, it is suitable for use in the area with irregular power supply. In the Iceland refrigerator, vaccine should be stored in baskets to avoid direct contact with the sides and the bottom. Since the bottom of the Iceland refrigerator is its coldest part, the most heat-sensitive vaccines should be stored at the bottom and the most heat-resistant vaccines in the top compartment. This is reverse of the domestic refrigerator. So the bottom includes measles, MR, MMR, BCG, OPV, yellow fever, live Japanese encephalitis, varicella, rotavirus, live attenuated hepatitis A vaccine.
Okay, the coldest should be the live vaccines. Okay, remember that way. And you might be asked a short note of Iceland refrigerator. You must be able to write that this is useful when where the electricity goes off. At least 8 hours supply must be there for in 24 hours. Therefore, whenever if the supply goes more 8 hours, you will have to transport the vaccine away from there. Okay, read it.
Middle and upper, all the pertussis containing combination vaccines, inactivated hepatitis A vaccines, typhoid conjugated vaccine, pneumococcal conjugate vaccine, meningococcal vaccine, inactivated influenza vaccine, HPV, rabies, and inactivated JE vaccines.
So these are the Iceland refrigerators, which they are telling. You understand? This is how it looks. It looks like a freezer to me. Iceland
Yes.
vaccine storage. See, all around they have kept ice. I think these are all probably ice. You have to keep the vaccine in a basket. Why? Because you don't want the ice to come in, this vaccine to come in contact with the ice. This is also probably ice. Okay, in this one, and they have written. You have a maximum minimum thermometer, condition ice and pack, freeze indicator, and freeze sensitive vaccine. If this is freezing is shown, then if it is in DPT is kept and it is sensitive, you might have to throw it away. That's what it is. Therefore, these ice line refrigerators. Okay, now come to the cold boxes. Cold boxes are what is used for the transport to a periphery. Read it first.
Which of the following is correct about cold boxes? A. Used for long-term storage at home. B. Used to transport vaccines from district to PHC. C. Can store vaccines for up to 30 days. D. Do not require ice packs. Used to transport vaccines from district to PHC, sir.
Okay, B, your correct answer. Now, next word.
How long can vaccines be kept in a 20-liter cold box at 43 degrees Celsius ambient temperature?
I don't know, 43 degrees centigrade? 43 degrees centigrade is enough? I don't know. Is it? Okay. How long can it be kept in a cold box? 20-liter cold box. Read it.
The answer is C, 6 days. A 20-liter cold box can maintain cold chain for 6 days at 43 degrees Celsius if not opened.
There are many questions in cold chain. You should know what is what is kept at the district level, what is done in a transport. A cold boxes means what? 6 days you can keep it at 43 degrees and you read what is given here. And you read.
Cold boxes or coolers. Cold boxes are big insulated boxes with ice packs. They are mainly used for transportation of vaccine from districts stored to the PHC. In an emergency, they can also be used to store vaccines and frozen ice packs. Before placing vaccines in the cold boxes, conditioned ice packs are placed at the bottom and sides of the cold box.
Okay, they are used for transport. In an emergency, they can use store vaccine. When does an emergency come? The emergency comes when the current goes off. That's all they are telling. And they're telling you can store it for 6 days. Can you read what is given in the...
Vaccines can be kept in a 5-liter cold box for 90 hours and a 20-liter cold box for 6 days when the ambient temperature is 43 degrees Celsius, provided that the boxes are fully functional and not open during this period.
Sorry, there's an ambient temperature. What do you mean the ambient temperature outside? Okay, not inside. That's what confused me. Ambient temperature is okay. Now we go to the next question.
Vaccine carriers are used to carry vaccines for a long distance transport, B, 1-day outreach sessions, C, storage at district hospital, and D, freezing diluents, B, 1-day outreach sessions, sir.
Okay. For health workers, when they carry the vaccine carriers are used.
How many conditioned ice packs are used in a vaccine carrier to maintain +2 to +8 degrees Celsius?
Well, it will be difficult for you. There are 4 sides for the carrier, therefore it must be 4. You understand? 4 conditions. See, when I went to the health center, when I went to our PRS immunization clinic and I wanted to carry a vaccine home, she asked me the same question: how many ice packs you require? I said 2. Actually, it should have been 4 because you have to keep it on all the 4 sides in a vaccine carrier. Okay, for 1 day. You can take it for 1 day. All right. Read it, vaccine carrier. What is bracket?
Vaccine carriers. It is used by health workers for carrying vaccines 16 to 20 vials to subcenters or to community outreach programs. They maintain the cold chain during transport from PHC for 1 day use in the field. The inside temperature is maintained between +2 to -8 degrees Celsius with 4 conditioned ice packs for 1 day.
Is it minus?
It's +8 degrees Celsius, sir.
Before that, they had written plus. I think it is a mistake there, is it not? Okay. I'll have to find out. Okay. Okay.
What is sweating of ice packs? A, melting ice packs completely before use. B, warming frozen ice packs until ice moves freely inside. C, washing ice packs with soap. D, refilling ice packs with saline. Sweating.
Actually, I was a little surprised at the answer. I didn't know it before I went through it. Anju, you are there? Anju is gone. Okay, they see when you carry an ice pack, read the answer now.
Sweating involves removing ice packs from the freezer and shaking until ice moves inside, preventing freeze damage to vaccines.
Well, therefore, take it from the freezer and put it in your carriage. You understand is wrong. You should make it sweat. Sweat means more. Keep it outside and keep shaking till the ice starts moving. Otherwise, there will be freeze damage to your vaccine. I didn't know that. Very frankly, you can read it. Your ice pack. You read the ice.
Ice packs. Ice packs are flat, leak-proof plastic containers of standard dimensions that should be filled with tap water to fill about 80% of the capacity. They are kept in deep freezers at minus 25 degrees Celsius till they are frozen. When removed from the freezers, the temperature of the frozen ice packs is minus 20 degrees Celsius, which can damage freeze-sensitive vaccines. The frozen ice packs have to undergo a process known as sweating to make it suitable for use. Sweating is done in the following way. The ice packs are placed on a table. The ice packs are shaken every few minutes till the ice is noted to move around the ice packs. This may take a few minutes to an hour. They are now ready for use in vaccine carriers and cold boxes.
It may take a few minutes to an hour. Remember this. And when you want to transport, the vehicle will be waiting outside. They will come give the vaccine. You will take the vaccine. You will put the ice pack straight. That's what I have done in health center for years. And now only I read about it. Anyway, summary of cold chain equipment under expanded program on immunization. There is electrical as well as non-electrical. There is something called deep freezer, minus 15 to 20, 200 OPV is used in deep freezer. Okay. I don't know what you mean by holdover time. I mean, that means you can, if that goes away, it will hold for 18 hours, 32 degree, I don't know. Then ILR is, we have seen ice, what is it, lined
Ice-lined refrigerators.
data. 2 to 8, there you use the other vaccines are kept, and it can be kept for 3 months. Therefore, deep freezer also 3 months, here also 3 months. Cold box, all vaccines stored for transport in case of failure, plus 2 to 8. Vaccine carrier plus 2 to 8. Deep freezer is here. Okay. Cold chain equipment, if you can remember, is great. All right. Now about domestic vaccine storage. In my house, when I started my practice in my house, I mean, when I was a tutor, I used to give vaccination at home, and I used to keep the vaccine in my fridge. Now read it.
Why are domestic refrigerators not ideal for vaccine storage? A, they are too large. B, temperature fluctuate with door opening and defrost cycles. They cannot reach freezing temperature. D, they are too expensive. B, sir, temperature fluctuate with door opening and defrost cycles.
Okay, opening and post the defrost cycles. Now I think we have fridges which don't defrost, which don't require defrost, I think. But whatever it is, you will open it for 10 times, which you're not supposed to do. Now, this is very important for you to understand. If you start your practice and at home, you start giving vaccination, many of us used to do it. My sincere advice is don't do it. Because if you have a reaction, you will not be able to treat it. But if you are giving it, can you use your domestic refrigerator? This can be a question, very practical question, which can be asked by an examiner. Okay, go ahead.
Domestic refrigerator. For vaccine storage, the domestic refrigerator has following drawbacks. Temperature varies significantly every time the door is opened. Temperature rises during defrosting in cyclic defrost and frost-free refrigerator. Cabinet temperature is easily affected by ambient temperature. Temperature setting using dial is crude and inaccurate.
Okay, these are points there. Okay.
Which of the following is recommended practice for vaccine storage in domestic refrigerators? A, store vaccines in the door racks. B, keep food and vaccines together. C, use a dedicated refrigerator only for vaccines. D, set temperature using a visual dial without monitoring. C, sir.
Yeah, you have to have a dedicated without food or medicines, ensure better temperature control and safety. If you are keeping your food, keeping your Coca-Cola and freeze and everything else, is a very better. If better, don't do it. Okay, read it. If following, yeah.
Safe vaccine storage is possible in domestic refrigerators if following points are observed. Store vaccine in a dedicated refrigerator. Do not store food, drinking water, or other medications in vaccine refrigerators. The refrigerator compartment temperature is maintained between 2 and 8 degrees Celsius, and freezer compartment temperature maintained at or below 5 degrees Fahrenheit, that is minus 15 degrees Celsius. The door seals are in good condition and are sealing tightly. The door closes properly automatically on leaving it free. The refrigerator has separate freezer compartment. The refrigerator compressor is quiet. The refrigerator is free from any coolant or water leak. Vaccination clinic staff is well aware about vaccine storage plans.
Most important that you should not have a switch to the cutting off the electricity to a fridge. If it has a switch, you should write there, do never off it. That's very important. Okay.
Where should the thermometer be placed in a vaccine refrigerator? A, in the freezer compartment. B, on the door. C, in the center of the vaccine storage compartment. D, on the top of the refrigerator.
Where is it?
C.
Yeah. Okay. Read it.
The thermometer probe should be placed centrally among vaccines for accurate temperature monitoring.
I'm going very fast because I think you have read it. Okay.
Tips for better.
Your vaccine. Yeah, this is important when you practice. Okay. Should
Tips.
we read? Yeah. There are about, we have overstepped the time. There are about, I think 18 slides more. Can we go another 15 minutes so that we can finish it off? All right. We'll go fast.
Okay,
I think this is, you can read it later. It's not very important, but read what is next.
Avoid unnecessarily opening the refrigerator door. The WHO recommends door openings be minimized to not more than 4 times a day. Monitoring temperature inside the refrigerators. Monitor internal temperature regularly with thermometer, preferably Celsius digital minimum or maximum thermometer. Place the thermometer in a central location within the storage compartment. Safeguard the power source. Ensure the power source is marked clearly in a way to prevent the refrigerator from being accidentally unplugged or turned off.
This can be a catastrophe, I'm telling you. Without knowledge, somebody may off the fridge and that will be problematic. And remember that it cannot be opened more than 4 times. Therefore, the WHO does not say that you cannot use a domestic refrigerator. Understand that. You are allowed to open, but you cannot keep anything else in the fridge. That's the important thing.
What is the purpose of increasing cool mass in a refrigerator? To make the refrigerator heavier, to improve aesthetics, to stabilize temperature using water bottles or gel packs, to reduce electricity consumption. To stabilize temperature.
Yeah, probably your guess is right. Yeah. Read it.
Adding water bottles or gel packs increases thermal mass, helping maintain stable temperatures during door openings or power cuts.
That's all. There you keep bottles on the side so that the power cuts, etc. Increasing cool mass. They can ask you a short. What is this? Yeah, read it.
Increase cool mass. Place water bottles in the door or the lowest shelf of the refrigerator and or ice packs or gel packs in the freezer compartment to increase the cool mass. These will assist in stabilizing the temperature in the refrigerator compartment and reduces warming periods when the refrigerator is opened. This is also useful if there is a short time power cut or refrigerator failure.
Very important. The next lines are also important. I hope you read it because remember, never store any vaccine in the door of the refrigerator. Here only ice packs can be kept. Okay, it will come up later.
Where should freeze-sensitive vaccines like DPT, hepatitis B stored in a domestic refrigerator? Freeze.
Therefore, you should know what is stored in a refrigerator in the top shelf, middle shelf, and bottom shelf. It will come up. The answer is freeze-sensitive vaccine should be placed in the middle shelf, away from the freezer and cold walls. Okay, now read it. In a freeze drive, read
Place
this.
measles, MR, MMR, BCG, OPV, yellow fever, JE, meningococcal A conjugate, Rotavac, and or any other vaccines not damaged by freezing on the top shelf. Put DTP, DT, TD, TT, hepatitis B, DTP or Hep B, DTP or Hep B, uh, DTP, Hep B, influenza B, IPV, PCV, HPV, rotavirus, and or any other free sensitive vaccine in the middle shelf. Store the diluents next to the freeze-dried vaccine with which they are supplied on the appropriate shelf. If there is not enough space on the shelf, put the diluents on the bottom shelf, clearly labeled so they can be easily identified to their matching vaccine. Heat stable vaccines like PCV, HPV, TCV, HPV, and rabies can be stored in the lowest shelf for short periods.
Remember, how can you remember? Top shelf, it will be OPV, live viral vaccine, and only vaccine which I find is surprisingly is meningococcal conjugate vaccine, which is a kill vaccine. All others are killed vaccines, is it not? HPV, rotavirus is again a live vaccine. I don't know why it is not stored in the freeze-sensitive vaccine. I think rotavirus is a freeze-sensitive virus. Unlike there's something information to me. Therefore, you must know this is a very common question asked: what vaccine you keep in the top, what vaccine you keep in the middle, what vaccine you keep in the bottom. Therefore, this is what it is. Bottom is only bottles. You don't normally keep vaccine there. Safeguard that you must write on it, do not turn off. This must be do not unplug. Both of this should be written clearly. That's what they say. And the water bottles are kept for what? To increase the cool mass, which we have already seen. Okay. And now here comes the thing: measles, MMR, BCG. But I thought DPT and DT combination vaccines are kept in the middle one. Here they have shown here. I don't know why they did it. There are only two storage pattern. Better is this diagram. See, this diagram is very good. Store pack upright to avoid leaks. Okay, these are packs, storage pack to leak. Nothing in the chiller temperature, chiller tray, nothing. OPV can be stored in freezer. Only vaccine in freezer is OPV. Top shelf, you have OPV, freeze-dried vaccine. Here is written Rota also. See, this is the problem with our immunization. Just before this, they have written Rota in the middle, and now is it not? They have written rotavirus in the middle shelf, and now here they have shown, yeah, it is middle shelf. Huh? No, yeah, nothing in the top shelf. You have freeze-dried vaccine, BCG, MMR, Rota also, top shelf. Middle shelf, you have the other vaccine. Lower shelf, you usually do not keep the vaccine, but if you want, you can keep HPV, rabies, and hepatitis. Non-drinking bottles to maintain cold mass. You can keep bottles, but you should not keep the drinking water, because drinking water you will keep on opening, and you should not open this fridge for more than 4 times a day. Therefore, these are very practical questions which can be asked to you.
Which device provides continuous temperature recording and alarm for excursions? Vaccine vial monitor, data logger, mercury thermometer, or hygrometer?
What is it? Continuous thermometer temperature monitoring is done by data logger. Okay.
Data logger record temperature electronically at intervals, provide alarms, and help create a temperature map of the storage unit.
Okay, is there anybody other than Majida? Is there Ashwati there? Ashwati gone. Paris?
Yes, sir.
Ashwati, you are there?
Yes, sir.
Now you read it, because she might have got so now I think you better read the whole thing. What is written here?
Digital thermometer. There are most accurate constant monitors and also offer alarm to safeguard against damage from the refrigerator malfunction. To get accurate reading, place the temperature probe in proper location. Data loggers. This temperature chart recording system can record temperature over a long period of time, as well as can provide visual and audio alarms. Loggers use a similar measuring principle to chart as recorders, but record the data electronically. The objective of data logging is to build up a temperature map of vaccine storage areas within the refrigerator to identify the safest areas and the most dangerous areas for vaccine storage particularly looking for areas where vaccine could freeze.
Where there were long period they will store. Okay, read it now.
Each logger is a self-contained miniature computer. Once programmed by the computer, loggers are disconnected from the computer and placed in a vaccine refrigerator in close proximity to the temperature probe. The logger then operates independently on its own battery until the recording is downloaded to the computer. Temperature of ice-lined refrigerators or the freezers used for storage of vaccines must be recorded twice daily at 10 a.m. and 4 p.m. This should be recorded in a logbook. All cold chain temperature monitoring device should be calibrated once in 6 months or earlier if necessary.
Okay, these are too much details, but you must at least know what is logger, what is freeze-dried vaccine, I mean ice-lined vaccine, refrigerator, etc. Once they ask vaccine vial monitor as a short note. Can you say what is it? What does a vaccine vial monitor? Read the answer.
What does vaccine vial monitor indicate? Option A, exposure to light, cumulative heat exposure, freezing exposure, and vaccine expiration only. Option D.
B, yeah, it only it shows contain heat sensitive material. Okay, read it fast. Ashwati.
Vaccine vial monitor contains heat sensitive materials that change color with cumulative heat exposure, indicating potential potency loss.
Only the heat, not the light. Okay. Read it, okay.
When the VVM is on the cap or the neck of vial, how long can the vaccine be used after opening? Option A, 28 days, B, 14 days, C, 6 hours, or until the session ends. Option D, 48 hours. Answer C.
Yes, given.
If
It's not
VVM
in the
is
label.
not,
On cap or neck, the open vial must be discarded within 6 hours at the end. That is VVM. We will come to that later. Now we'll show what it is. You have to read this. See, vaccine vial monitor has been asked as a short note once. Remember this. Therefore, read the whole thing.
vaccine vial monitor.
Yeah.
A VVM is a label containing heat-sensitive material which is placed on a vaccine vial to register cumulative heat exposure over time. A VVM enables the health worker to know whether the vaccine has been damaged by exposure to heat. A direct relationship exists between the rate of color change and temperature. Thus, VVM gives information about the heat exposure over a period of time that affects vaccine potency. It doesn't give information about other factors responsible for vaccine degradation, such as light. VVM are not substitute for expiry dates.
This much, if you write, I think you have written a short note. Now, actually, I have not seen a VVM to tell you. Have you seen it? Have you seen a VVM? Vaccine vial monitor. See, this is, you have seen it, huh? Who's this?
Yes.
Ashwati, you have seen VVM in your...
Sir, it is routinely present in the oral polio vaccine, sir. And in our pulse pole immunization and all.
All right, that's great. That is, if it is white, it is okay. I think it is, some of them are on the vial. For here, if it becomes color like this, then you cannot use it. That's what it is. Decision to use vaccine based on vaccine vial monitor. Therefore, this is asked a short note, you should know it. Now they said something on the cap, something on the vial. That will come up, I think, in, or read it now what it is.
In multi-dose vials where the VVM is attached over the label, the vaccine vial, once opened, can be used for next 28 days, liquid or freeze-dried. When the VVM is attached anywhere other than the label, example cap or the neck of the ampule, the vaccine vial, once opened, must be discarded after the immunization session or within 6 hours of opening, whichever comes first.
So this is the important. Here, both the VVMs are on the label. Once you open it, I think you can keep it for 28 days. If it is on the cap or anywhere else other than on this one, you can use it only for 6 hours, is it not? Next 68 days, liquid or freeze dried. The other one you had to, these things I did not know. A cap or neck. Cap or neck means if it is here on the cap or neck here, then once you open it, 6 hours or on the same immunization day, whichever is earlier. Can you go ahead now, read it?
What is the function of electronic freezer indicator? Example, freeze tag. Option A, monitor light exposure, monitor heat exposure, detect freezing of freeze-sensitive vaccines, D, track a vaccine expiry.
The answer is given, is it not? Answer,
C,
yeah.
freeze indicators like freeze tags detect if freeze-sensitive vaccines, example, DPT, hepatitis B, have been exposed to freezing temperatures.
Okay, now we go to there's so many electronic freeze indicators. Read it, yeah.
Electronic freeze indicators. These are devices used to monitor the exposure of vaccines to freezing and are used with freeze-sensitive vaccines like DPT containing vaccines, hepatitis B, TT containing vaccines. The most commonly used type of freeze indicator is freeze tag. This consists of an electronic temperature measuring circuit with an LCD. A small blinking dot of light in the corner of display shows that the freeze tag is functioning correctly.
Okay, now see, this is what it is. Freeze tag, what you call alarm condition -5 to. This means it shows this. See, this is how the freeze watch is there. I think freeze tag is. I don't know how you read it. It might show alarm means it shows this one, and OK means it shows like that in a freeze tag. In a freeze watch, okay, there is the color change, darkened paper activated. Now this is and darkened paper activated, and this whole thing is darkened. That means you can't use it. If you read it, what is it? They are devices used to monitor the exposure of freezing. These kinds of electronic temperature measuring circuit, a small blinking light. Okay, therefore, there are electronic freeze indicators also. That's what you should know, and that can be freeze tag or a freeze watch. I'm not knowing too much. Anju, you have any experience regarding this? I think it's not there. Okay. Lastly, what's the last question?
What is e-win? Option A new vaccine for infants, an electronic network for real-time vaccine stock and temperature monitoring, a type of call box, a training program for pediatricians. Option B.
Yeah, okay. Read it.
Electronic Vaccine Intelligence Network is an IT-based system for real-time monitoring of vaccine stocks and temperature across India, introduced in 2015.
It is introduced in 2015. Did you know about it? I didn't know about it. This 2025. Thanks to my attempt to teach you people vaccination and reading this purple book page to page, I came to know there's an electronic vaccine intelligence network all through India.
Yes, sir, that is correct, sir.
Oh,
Yes, sir. The GPHNs and the field people are actually routinely filling up the data in this, electronic vaccine intelligence network, sir. It's happening, sir. Thank you.
oh, electronic vaccine. But you don't have to fill up data, isn't it? It must be automatically recording, I think. I don't know. And
Not sure, sir.
okay, read it now. What is in the bracket?
Electronic Vaccine Intelligence Network. Electronic Vaccine Intelligence Network is an IT-based system aimed at strengthening vaccine supply chain system across the country. First introduced in 2015, even enables the real-time monitoring of vaccine stocks and the storage temperatures in multiple locations across the country.
My God, I never knew it. Now read it now. What is it? Can
All
you?
cold chain handlers are provided smartphones having an application that allows for digitalization of vaccine inventory, real-time stock, and temperature vaccine requirement. emergency management, consumption pattern, route planning, and the stock reallocation.
God. Yeah.
SIM-enabled temperature loggers are attached to the cold chain equipment and capture temperature information through digital sensors placed in the ice-lined refrigerators. Temperature data is recorded every 10 minutes and updated at interval of 60 minutes on the server via the General Packet Radio Service (GPRS). In case of temperature breach, the logger alarm and send email and SMS alerts to the concerned technicians and managers. It has been implemented in all 36 states and the 733 districts with over 29,000 storage centers or cold chain points which are live on EVIN. EVIN has achieved a vaccine availability rate of over 99% at all cold chain points and over 80% reduction in instances of vaccine stockouts.
If they ask you electronic vaccine surveillance intelligence network, actually, I never knew about it. Anju, did you know it was so much advanced?
Yes, sir. But we are not directly involved. The field staffs are given enough training and they are being supervised. It's
And they're given
something like a
smartphones.
parallel thing.
They're given smartphones.
Yeah.
My God.
Actually, smartphones, those things are there.
Finally, I will end up telling that I overstepped the time, but I must tell you my question, my MD examination when I appeared, it was a dream exam for me. No question went unanswered. My cases were fantastic, and I knew that I would pass and get a very good mark. And many times the examiner said, good, 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 till the end. Till the end, the oral final question he asked me, Doctor, you are in a primary health center and you are going for a vaccination field. You are taking a box, cool box with ice and vaccines along with you. You go about 3 or 4 hours, you walk and you go to a school. How do you know whether the cold chain has been maintained? That was the question he asked. Now I told him that there is at that time there used to be a temperature which show thermometer which will show the high and the low at the thermometer. He said, Doctor, these are all in the books. It's not available. Then I said, I will make sure that the box is not opened. I may carry. He said, no, you are going and you're opening the box. How do you know? I started sweating because I didn't know the answer. And then everybody started laughing, including Sugunabai madam. And madam said, this is the problem. He knows the rarest side effect. He knows how to discuss the case. He said, look, when you open the box, the ice is already melted and water. You should simply cancel the vaccination and go back. That was the answer he gave me. From that time to date, tonight, the way in which immunization has changed, I'm really surprised. Okay.
Sir, I'm not sure whether they are given smartphones individually. Most of them have smartphones. I'm not sure of that part, sir. Anyway, they're using the software. That is also okay, sir.
Okay, thank you. I'll close it now. Let me stop sharing, and I'll also stop recording.